The new drill for taking the witness out. Well, before the.
If he says, which he usually does, you're now free to go, there's no need for you to stay. Good afternoon. The hearing will begin shortly. May I remind you to check your mobile phones or any other electrical equipment you have with you are on silent mode. Members of the public and reporters in the hearing room are not permitted to use any electronic devices during the hearing. If you wish to do this, you can do so in the annex. No food or drink may be consumed in the hearing room except for the water provided. And may I remind you to please remain seated until the witness and the chair have left the room.
Yes, Miss Whitelaw.
Good afternoon, sir. Mr. Faulkner, my name is Francesca Whitelaw, and as you know, I ask questions on behalf of the inquiry.
I swear by Almighty God that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Thank you. Would you like to sit down, Mr. Faulkner, because that's where the microphones are.
Could you give us your full name, please?
I'm John Charles Mark Faulkner.
And you're known as Mark Faulkner, is that correct?
That's correct.
Thank you very much for attending today to give evidence. You should have in front of you a copy of a report that you've made for this inquiry, which runs to 89 pages. I'm just going to ask for the front page to be brought up on the screen, please. The reference is INQ 005942. Do we see there that it's dated the 10th of August 2024?
Yes.
And if we could turn to page 82 of that document. Do we see there, first of all, a statement of truth, which reads, "I confirm that I've made clear which facts and matters referred to in this report are within my own knowledge and which are not."
Yes.
Those that are within my own knowledge I confirm to be true.
Yes.
The opinions I have expressed represent my true and complete professional opinions on the matters to which they refer.
Yes.
So just to confirm, you made that declaration
Yes.
and you confirm it now.
Yes.
We see below that an expert's declaration, and I won't read that one out, but if you could just have a look at that now. And sir, as you described it this morning, this is a standard form of words, which is within the rules of court for both civil and criminal procedures. If we could turn over the page when you've had a chance, have you had a chance to look at that
Yes.
declaration? Thank you, to page 83. And did you make that declaration and sign the report where we see the redaction for personal data?
Yes.
So with your permission, the whole report will be adduced and published on the inquiry's website in the usual way.
Yes.
Mr. Faulkner, if we could start then, please, with your professional qualifications and experience, which you set out at page 4 of your report. So, first of all, your qualifications. Do you hold a degree in paramedic science from the University of Hertfordshire?
I do.
And a master's degree in resuscitation and emergency medicine from Queen Mary's University of London?
I do.
Do you also hold postgraduate master's level qualifications in advanced paramedic practice?
Yes.
As well as a postgraduate certificate in point of care ultrasound?
Yes.
And are you also qualified as a paramedic?
I am, yes.
Secondly, your roles then. Firstly, could you tell us your current role?
I'm currently Associate Clinical Director and Consultant Paramedic within the London Ambulance Service.
Thank you. If you could slow down a little bit for the transcriber, thank you. Is that one of the lead clinical paramedic roles within the Trust?
It is, yes.
Your report indicates that you are a senior clinical manager within the clinical directorate and that you sit on the Trust's Executive Leadership Committee. Is that correct?
That's also correct.
Are you also an advanced paramedic practitioner critical care?
I am, yes.
So does that mean you're a practicing clinician?
Yes, I practice about 12 hours every week in clinical practice.
Or did you say every week?
Yeah, every week.
And is that as a critical care responder on ambulances or response cars? Or?
It's normally as a critical care responder on ambulances, but it's also on response cars. But I also work in ambulances, more routine response cars within our control room, or as all part of that.
So within the operations centre as well?
Yes.
Your report indicates that you have an additional specific portfolio of work, including major trauma, resuscitation, cardiac and stroke, medico-legal practice and governance. Could you just explain to us what that looks like in practice?
So I look after what we describe as acute and specialist care within the London Ambulance Service. So I'm the clinical lead for resuscitation, major trauma, stroke, as well as heart attacks. And I am involved in the oversight of that area of work, the review of cases in that area, and clearly that impacts on giving evidence in legal proceedings around those areas.
Thirdly, in terms of your qualifications and experience, your experience, please. You say in your report that you regularly review emergency calls and calls to NHS 111. Is that a quality assurance sort of process?
Yes, it's normally on addition to a routine quality assurance process. So senior review of 999 calls.
And in the 5 years prior to you making your report, approximately how many patients have you attended in cardiac arrest?
Around 250.
You indicate that you were previously the clinical advisor to the medical director of the London Ambulance Service. When was that, please?
Between 2010 and 2015, approximately.
And also that you were the clinical practice development manager for critical care. When was that?
2018 to about 2020-21.
Are you also one of the authors of the National Clinical Guidelines for UK Ambulance Services in respect of resuscitation?
I am, yes. I sit on the resuscitation committee of the Joint Royal College's Ambulance Liaison Committee, National Clinical Guidelines.
And have you also published various papers in major trauma, including patient assessment and including the management of cardiac arrest?
Yes.
And you say you have a clinical and academic interest into the efficacy of resuscitation and survival from cardiac arrest?
I do, yes.
Fourthly, in terms of your experience, could you just tell us the extent to which you're involved in the education and training of paramedics, please?
So I teach paramedics of all levels, from teaching really basic first aid. In fact, I teach some first aid to the scout leaders, right up to teaching medical staff advanced life support resuscitation.
Your report indicates that you're not a specialist in chemical, biological, radiological, nuclear and explosive emergencies, but that you have frontline experience, including attending a range of emergencies that include terrorist incidents. Are you able to give us some examples?
Yes, so I was a paramedic at 7-7 in the earlier part of my career. More recently, I was one of the senior responders to the Streatham incident. I was involved in the ambulance service response to both London Bridge and Westminster Bridge. I have been involved, so in terms of terrorist incidents, those are probably some of the key ones.
Thank you. Moving to the report itself then, for the purposes of preparing the report, could you confirm that you were supplied with a large number of documents, including, first of all, witness statements?
Yes.
Secondly, contemporaneous ambulance logs, call logs, and medical records?
Yes.
Thirdly, policies and procedures?
Yes.
And fourthly, post-mortem reports?
Yes.
And I'm looking at page 10 now of your report in paragraph 1.11 for you to follow. Could you tell us what the purpose of your report was, please?
I was asked a number of questions by the entire inquiry team, but with an overarching review of the ambulance service care to Dawn Sturgess, but also to consider the care to Mr. and Ms. Skripal and to Mr. Charlie Rowley.
So I think am I right that the purpose was to examine the management of Dawn Sturgess following her collapse and cardiac arrest on the 30th of June,
Yes.
primarily? However, in order to comment on that treatment, was it necessary to touch on both the responses to the collapse of the Skripals and also Charlie Rowley?
Yes.
And so you do that in your report, is that right? In terms
That's
of
correct.
Now, we've addressed your own qualifications and experience. And as a preliminary matter, I'd just like to ask you briefly about paramedics, because although lay people refer to all ambulance personnel as paramedics, that's not strictly correct, is it?
That is, yeah, what you describe is correct, that most people will describe anyone who works on an ambulance as a paramedic. A paramedic is a protected title, like being a registered nurses, and there are certain entry requirements to be on the register as a paramedic. So you register with the Health and Care Professions Council. Not all ambulance clinicians are paramedics. There are a number of what more generally today are referred to as associate ambulance practitioners. And their job titles do vary around the country. Emergency medical technicians, emergency care support workers, emergency care assistants are all a number of the job titles used nationally. An associate ambulance practitioner. They are not registered with the Healthcare Professions Council, so they are not paramedics. And in the main, their level of training is not as inclusive of paramedics, but for completeness, you will find emergency medical technicians who work with other emergency medical technicians as well as with paramedics.
So both are generalist clinicians, is that correct?
That's correct.
but paramedics are registered and trained to a higher standard generally.
Generally, yes.
And I think since 2018, paramedics have to complete an approved Bachelor of Science with Honours level degree programme, is that correct?
That's correct.
And in an ambulance, will the paramedic normally be the lead clinician?
Yes.
We've heard the air ambulance variously referred to in this inquiry, I think, as HEMS, ASB and critical care paramedics. Are those terms interchangeable?
So the air ambulances go under a number of different titles in the UK. Some get referred to as helicopter emergency medical services. Some are referred to air ambulances. The qualification of the staff who work on UK air ambulances is very variable. Some air ambulances employ paramedics with limited additional training, if any. Some air ambulances will employ paramedics who have got advanced practice qualifications. And there will be a number who employ paramedics or second paramedics who've got specialist practice qualifications. So there is a real mixture across the UK. And again, there is no consistency in job title. Some are referred to as critical care paramedics, others are referred to as advanced paramedics, some are just referred to as flight paramedics.
I asked Ian Parsons, the paramedic who attended Julius Skripal, why he requested the air support ambulance. I won't bring it up, but the transcript reference there is day 8, 30th of October, page 26, line 23. And he responded, because they carry critical care paramedics and they have enhanced knowledge, enhanced training and carry more drugs than we do. Is that a fair summary of why a paramedic might call for air support?
I think it's a fair summary of what an air ambulance may offer. Why a paramedic may call for them is because they may require some assistance or they believe there is some additional care that asset may be able to offer the patient with them.
Do we gather, Mr. Faulkner, that it may vary, the organisation and the staffing, as it were, of different units may vary from one service to another a little?
Yes, sir. Equally, it also varies within the service. You'll often find ambulance services who have 2 or 3 air ambulances, and they are not consistent.
Right.
Would you expect the local paramedics to know their sort of local air ambulance service and what they can offer?
Absolutely.
In terms of guidance, do all paramedics operate according to national clinical guidance?
So there is a national set of clinical guidance, which is a kind of cornerstone of paramedic practice. That is normally enhanced in trusts by some internal guidance, and depending on the ambulance trust, it depends how much additional guidance there is.
So we've heard the JR Calc guidelines. Does that stand for the Joint Royal Colleges Ambulance Committee in conjunction with the Association of Ambulance Chief Executives?
So the JR Calc is the Joint Royal Colleges Ambulance Liaison Committee, and their national clinical guidelines are published in collaboration with the Association of Ambulance Chief Executives.
Would you mind very much if I asked you to do it just a little more slowly?
Thank you.
Because people, including me, need to keep up.
Thank you.
In 2018, was the most recent version of the guidance published 2016?
Yes.
And I think we saw that. Did you watch the evidence of Professor Rutty this morning?
Yes.
And I think we saw there was an excerpt from one of his statements which referred to those guidelines. With reference to paragraph 6.5, which is at page 75 of your report, if you need it, can I ask you just at this stage what training or guidance you think paramedics should have received regarding the signs of and treatment for nerve agent before the Skripal poisonings?
So paramedics would have had an awareness of organophosphate poisoning. That would have included nerve agents, but it would have been quite limited.
In your report, you refer to holding the view that specific education on nerve agent exposure being covered at no more than the most superficial level at that stage. Is that what you'd expect?
Yes, I did, yes.
And did you have the opportunity to read or see the evidence of Wayne Darch in Salisbury?
I did, I have read it.
And could you confirm, you refer to in your report, that you've seen the duodote medicines protocol, which indeed was brought up today,
Yes,
of January 7, 2017, and the clinical notice regarding the implementation of duodote injectors?
yes.
Would you expect all ambulance clinicians to have been aware of those documents prior to March 18?
So those are internal documents for South West Ambulance Service. So I'd have expected their clinicians to be aware of them. They are not national documents, those specific documents.
Thank you. So you would have expected the SWAFT clinicians to have been aware of those, firstly in March 2018,
Yes,
and secondly by June 2018.
yes.
We'll come back to the post-Skripal period a little bit later, if we may. If I could ask you then some questions about medications. We've heard about various medications being administered in emergency response in these cases. And if I could confirm briefly the nature of each with you. So starting, please, with naloxone. What's the purpose of that?
So naloxone is an antagonist to opioids, which is the group of drugs that morphine belongs in, heroin as diamorphine belongs in, fentanyl belongs in. And it is a drug that competitively blocks the opioid receptor at a cellular level, and in essence acts as an antidote to opioids. So it blocks the effect of opioids.
We've heard it described as reversing it. Is that similar?
Yes, I think that's fair.
And how is it administered?
So there are various routes of administration of naloxone. It can be given into a vein, so you can put a cannula or a drip into the vein. You can put a needle into the bone marrow, so you insert a needle into the bone marrow and administer it, what is described as intraosseously or IO. You can give it as an intramuscular injection, so an injection into the muscle. And more recently, in the UK at least, it has been given intranasally as a spray up the nose.
And how safe is it to use in the pre-hospital environment?
So no drug is safe and every drug has side effects, but I would describe it as one of the safer drugs used in pre-hospital care. And often the challenge with naloxone administration is not the naloxone, it's the fact you reverse somebody's opioid effect and they are unhappy and then suffering withdrawal symptoms. That actually means it's the patient that's then the risk, not the drug.
We've heard that Sergei Skripal received naloxone intranasally from paramedic Lisa Wood. What was your opinion of that decision? And I'm referring to page 31, paragraph 3.42, if you need to refer to it.
I think it's a reasonable decision and I would have no criticism of that decision.
And why was that?
So, Mr. Skripal was found in a collapsed state. He had constricted or pinpoint pupils or meiosis. There was a level of respiratory distress. And of the things that would be common in those circumstances, and by far probably the most common, would be to think about an opioid toxicity and therefore administration of naloxone, a drug that has relatively few side effects.
So the paramedic's rationale being that she was considering opiate overdose and you'd consider that an appropriate treatment?
Absolutely.
How common is opiate overdose in a pre-hospital environment?
Extremely common.
We've heard evidence that Narcan is a brand name for naloxone.
That's correct, yes.
And in terms of treatment, I think Julia Skripal received naloxone as well.
That's my understanding.
And we're going to come to the treatment of Dawn Sturgess and Charlie Rowley. But staying with medications for a moment, diazepam, what is that, please?
Diazepam is a muscle relaxant. In an ambulance setting, it is normally used as an anti-seizure medication. So it's a muscle relaxant and anti-seizure medication, and it's used for the termination of status or continual seizures.
In your report, and I'm at paragraph 3.18, you say it's used to treat anxiety disorders or alcohol withdrawal. Diazepam is sometimes used to treat muscle spasms and stiffness or seizures. Can I just ask you why you qualify that with sometimes? What does that mean?
So there are other drugs that are sometimes used to treat seizures, and there are ambulance services now in the UK who use midazolam rather than diazepam for seizure management.
So you said that it's a muscle relaxant and anti-seizure medication. Does it enhance the activity of certain neurotransmitters in the brain?
Yes.
And how is that administered by paramedics?
So the reason I'm pausing is this isn't straightforward. Diazepam at the time was administered rectally as a stesolid, so a tube that was placed per rectum up the patient's bottom, squeezed, and the medicine was absorbed via the rectal route of administration. As one route, the alternate was a drug called diazomoles, which is an emulsion of diazepam, which can be given intravenously.
And I think we certainly heard evidence in this inquiry about diazomoles, so that's the dissolved preparation.
So it is an emulsion, so a lipid soluble.
And again, I think Sergei Skripal and Julia Skripal received that drug. Not Dawn Sturgess, again, we'll come to her, but Charlie Rowley did as well. Is that your understanding?
That's my understanding.
Next, then, I'll touch on atropine. We are going to come back to it in the treatment of Dawn Sturgess, but generally speaking, what is it?
Atropine is a drug that blocks the parasympathetic nervous system, so effectively blocks your relaxing and digesting, and has an effect of increasing heart rate, which is why it's a majority used in an ambulance service. It's normally used for patients who have a slow heart rate.
And we've heard of it being described as an anticholinergic, is that correct?
That's correct.
So that blocks the action of acetylcholine neurotransmitter at synapses in the central and peripheral nervous system. Is that an accurate description?
That's an accurate description.
So as well as assisting with slow heart rate generally, is it used to treat certain types of nerve agent and pesticide poisoning?
It is, yes.
And does it also decrease saliva production during surgery?
Yes, but that's not an indication for its use pre-hospitally.
Thank you. That was my next question. And I think we'll deal with in a moment that Sergei Skripal was given that in error, but I think not Julia Skripal or Dawn Sturgess in the pre-hospital environment, but Charlie Rowley was.
Yes.
In your report, you explain, paragraph 3.18, that medications are mainly administered in line with two specific schedules of the human medicines regulations, schedules 17 and 19. Could you tell us the difference between the two schedules?
So these are schedules of the Human Medicines Regulation. Schedule 17 is a variety of lists of medications that certain healthcare professionals who are registered can give in certain circumstances. included in that list is a list of medications specifically for paramedics, but there are also lists in that for midwives, podiatrists, and it is a very specific list of medications. Schedule 19 is a list of medications that anyone can administer in an emergency. So anyone sat in the courtroom, irrespective of medical qualification, would be entitled to administer that medicine. So for an example, sir, adrenaline auto-injector in somebody having an allergic reaction or an anaphylactic reaction.
So which schedule is diazepam in?
Diazepam is a Schedule 17 drug.
So paramedics.
Paramedics.
Atropine?
Is a Schedule 19 drug.
So that's anyone in an emergency situation. And you don't say in your report, but is naloxone in one of those schedules?
It is. It's a Schedule 19 drug.
So again, that's anybody in an emergency
Yes.
situation. Now, in terms of treatments next, we've heard that Julia Skripal needed assistance with her airway, and that first of all, an oropharyngeal airway was inserted, and then secondly, it was changed to an eye gel. You've provided some pictures in your report, so if perhaps we could have a look at those. INQ 005942, page 25. Could you just explain these different devices?
So the figure 1 device is an oropharyngeal airway or an OP airway, and it is a small plastic tube, 3 to 4 inches long in an adult, that's curved. And the idea of it is it aids ventilation, particularly by stopping the soft palate or the base of the tongue and supporting it. So when somebody's unconscious, their muscles relax. And what can occur is the soft palate can fall backwards and posteriorly. So the oropharyngeal airway, shown in the photo, provides some support to that.
Thank you. We heard evidence that an ICU doctor, Helen Ord, who was one of the passers-by and attended Julia Skripal, described a Goodell airway, and Ian Parsons indicated, the paramedic indicated it was the same as this airway. Do you agree with that?
Yes, Goodell airway is simply an old trade name for it.
And then we see the eye gel. Can you just explain the difference?
So an eye gel is a more invasive airway. In order to use it without the aid of drugs or muscle relaxant, the patient has to be more deeply unconscious than you would for an OP airway or an oropharyngeal airway. And this is a malleable plastic cuff that sits right at the back of the throat, above the vocal cords, and directs air, or aims to direct air and ventilation through the vocal cords into the trachea or windpipe and the lungs. It's a much longer device, as you'll see in the picture.
So although the first one is hard plastic and the second one is more malleable,
Yes.
It's the second one that's more invasive, if you like.
Yes.
And is that also, I think eye gel is the brand name.
Eye gel, so they are described as supraglottic airway devices, so devices that sit above the glottis. Eye gel is the most common one. The other one, for completeness, is called a laryngeal mask airway. And rather than having a soft kind of plasticine type cuff, it actually has an inflatable cuff.
Thank you. We could take that down. I'd like to move on to the signs and symptoms of opiate overdose on the one hand and organophosphate poisoning on the other. So if we could go back to your report, INQ 005942, but page 29, please. First of all, do you set out there at paragraph 3.38 that opiates are narcotic analgesics?
Yes.
And then you list some examples of medications included in the opiate groups. We have codeine, and then we need to go over the page. And then tramadol, morphine sulfate, diamorphine, heroin, fentanyl, and carfentanil. In that list then is fentanyl, and we heard from Dr. Helen Ord, whom I've just mentioned, the ICU doctor passing who assisted with the Skripals, that she was familiar with fentanyl in a clinical setting used in anaesthetics. And we heard from Ian Parsons, the paramedic who treated Julia Skripal, that street fentanyl is not prepared in a vial and taken intravenously like in a clinical setting, but is prepared in a patch and used transdermally. To what extent are either or both of those within your knowledge and experience?
So fentanyl can be administered transdermally and is used in pain management in end-of-life care as a patch. Fentanyl as a recreational drug can be injected, and you do see reports occasionally of heroin being cut with fentanyl, and you see particularly potent heroin available as a street drug because it's been mixed with fentanyl.
That was the next question I was going to ask you about, because you mentioned that in your report, that fentanyl can be mixed or cut with street heroines, diamorphine, resulting in a more potent drug, which is what you've just said. You also add it's not recorded reliably how often that occurs. Is that something of which you'd expect paramedics to be aware when dealing with potential opiate overdose?
So I would expect paramedics to be aware of varying strengths of heroin cut with other substances or mixed with other substances, particularly potent heroin. And I'd expect many paramedics to have an awareness of cases where heroin has been mixed with something. The reason it's not reliably recorded is there's no such thing as a reliable drug dealer.
In 2018, would you have expected paramedics to be aware of fentanyl?
Yes.
Also in your list is carfentanil, and we heard from Dr. Cockcroft, a consultant who treated the Skripals, that carfentanil has a potency hundreds of thousands of times greater than fentanyl. He said that fentanyl itself is an extremely potent opiate, but carfentanil is off the scale. Do you agree?
Absolutely.
And Dr. Haslam, another treating hospital clinician, explained that fentanyl is a drug of abuse and carfentanil is not. And Dr. Cockcroft said it would definitely be an assassination attempt if one deployed carfentanil. It could only have one purpose, and that's to kill. Again, do you agree?
Yes.
Continuing with this document, and if we could look at paragraph 3.39, do you set out there the JR Calc guidelines description of the signs and symptoms of opiate overdose?
I do, yes.
And does your footnote 11 there indicate that these are the current guidelines dated 2021?
They are, yes.
So we see there drowsiness, nausea, vomiting, small pupils, respiratory depression, cyanosis. Is that the bluish purpley colour skin?
Yeah, bluish purplish discoloration to the skin, indicating a low level of oxygen.
Decreased level of consciousness, convulsions, non-cardiac pulmonary edema. Is that fluid on the lungs?
So it's fluid on the lungs, and it's often seen as patients coughing up fluid or having sputum or bubbly fluid coming out their lungs.
And the non-cardiac meaning not heart?
Not caused by the heart, yeah.
Are you able to help us with whether the guidelines in 2018 indicated those same symptoms?
They are. I checked the old guidelines.
And then at paragraph 3.40, we can see you say there Mr. Skripal was presenting with meiosis, pinpoint pupils, reduced level of consciousness and vomiting. In addition, it was known to ambulance clinicians in that area of Salisbury there was known opiate drug abuse. So there the symptoms being within the guidelines for opiate overdose.
Yes.
And you say, I'm therefore by no means critical of LW as Lisa Wood's immediate impression of a potential opiate overdose. And you've explained already you thought it was reasonable to administer naloxone.
Yes.
So then we see at paragraph 3.41, you set out the JR Calc guidelines list of clinical features of organophosphate nerve agent poisoning. It says there the characteristic features of nerve agent poisoning: meiosis, excess secretions, for example, lacrimation and bronchorrhea. Is that the watery sputum from the lungs?
So it's watery sputum from the lungs, yes.
respiratory difficulty, for example, bronchospasm or respiratory depression, altered consciousness, convulsions, together with a history of possible exposure. Again, is this from the 2021 guidelines?
It is, but it is also unchanged from the earlier guidelines.
Am I right? The only change is not as to these presentations, but now we've heard FT49, a witness, refer to as an algorithm called CRESS. A toxidrome flowchart has been added, is that correct?
Yes, yeah, toxidrome kind of spreadsheet, if you will.
But I think that wasn't in place at the time of Amesbury, is that correct?
That's my understanding.
But these symptoms were the same?
Yes.
Now, to what extent do the symptoms listed there in your paragraph 3.41 appear in other presentations?
So there is considerable crossover of the symptoms. There is no single symptom that would indicate that something is an organophosphate or a nerve agent. You will see there is considerable crossover between the symptoms of opiates, an opiate overdose, and those of nerve agent. You see constricted pupils or meiosis. You see secretions from the lungs, a bit subtly different, but at the side of a road, you would be close to impossible to work out which was which. You see a level of respiratory difficulty. So there is considerable crossover. You also see crossover with other medical conditions. You see pinpoint pupils in brainstem hemorrhage and brainstem stroke.
Can you slow down a little bit?
Sorry.
Thank you, this is very helpful. So first of all, crossover between organophosphate poisoning symptoms and opiate overdose, but also now you're moving on to mention there are some of these symptoms that present in other medical conditions altogether, and you mentioned pinpoint pupils occurring in brain.
You see pinpoint pupils in some brainstem hemorrhage and some brainstem strokes. You also will, in patients who have significant brain injuries, see a neurogenic pulmonary edema, so increasing in secretions from the lungs with significant brain injury.
Sorry, just slow down a minute. Secretions from the lungs in what?
Insignificant brain injury or brain
Thank you.
bleeds. Sorry, sir.
That's all right.
And these are examples, are they, rather than an exhaustive list?
Absolutely, there is considerable crossover. I think it would be fair to say there is no silver bullet that identifies a single toxic substance in what we're talking about. There's nothing that you would say, you've got that, therefore it's that.
You do say in your report that you're of the view that hypersalivation would be the most sensitive sign of organophosphate poisoning. Is that something you stand by now?
I think it is, but you've also, I'm kind of minding what I said slightly earlier, is that hypersalivation and excess secretions are not just seen. And if you imagine a patient at the side of a road, it's really difficult to determine, is that hypersalivation from the oral pharynx or from the mouth? Or is it fluid coming up from the lungs as pulmonary edema? That's not an easy determination to make when you're kneeling on the pavement or at a side of a shopping centre or in somebody's living room.
And I think as well as having some symptoms that have been demonstrated in these cases that you're indicating could be also present in other causes. Also, is it right that not all of the patients in these scenarios exhibited all of the symptoms of organophosphate poisoning? And I'm thinking particularly of Sturgess not demonstrating the convulsions or respiratory difficulty that is in the list.
That's correct.
If we could just go to the bottom of the page there, I'm going to read this section here. You continue to say, there's a considerable crossover between the symptoms of opiate and organophosphate overdose. I should emphasise that opiate overdose is overall a relatively common presentation in the pre-hospital environment. However, organophosphate poisoning, whether accidental or deliberate due to nerve agent use, is extremely rare within the ambulance service. I would be of the view that the vast majority of ambulance clinicians would never see an organophosphate overdose in their careers. In addition, I would be of the view that most ambulance clinicians would expect a nerve agent release to be a large-scale event with multiple patients presenting with similar symptoms following a significant exposure. To put this in context, I have worked in pre-hospital care for 25 years in an extremely busy service and having worked internationally. I have seen one patient who presented with an organophosphate overdose. This patient was in their garden shed lying next to a packet of organophosphate insecticide. Pausing there, the implication being that it was very easy there to hypothesise what had made them collapse, is that?
I think it was probably one of the most obvious causes of collapse in my 25-year career.
And you go on the last shift I worked, are you referring there to the shift you did immediately before preparing?
I think that was a Friday night as I was drafting the report on Saturday morning.
Right, so on the last shift I worked, I saw a patient with an opiate overdose and would be unable to precisely count how many hundreds of opiate overdoses I had seen. I would consider it unusual for me to have seen one organophosphate. Many colleagues cite that they have never seen a single case. Now, when preparing your report, you were asked how common or rare it was for a paramedic to attend a patient who suffered nerve agent poisoning and to include relevant statistical evidence of which you were aware. So if we could go to INQ 004691 and page 4. We could make that a bit larger, please. These are from a set of DSTL slides that we've seen before in the inquiry. And does that list all the nerve agent poisoning of which you're aware, or are you aware of others?
I think those are the ones that I am aware of.
And we see the March and June 2018 poisonings. Are those the only ones you're aware of having occurred in the UK since that time period, since 1988? That's
my understanding. I think there is something that's probably worth pointing out at this point. And I'm probably a bit of an ambulance geek, and I had in my head a mental model of what a nerve agent release would look like prior to Salisbury. I'd thought about this. You kind of take the learning from Tokyo and bits like that. These were all releases as an inhalation, not a dermal exposure. And I think our learning at that point, prior to Salisbury, was around that atmospheric release as opposed to that dermal exposure. And there is a subtlety of difference in symptoms that one might expect, given those two absorption routes.
Thank you. Now, we could take that down. With reference to your report, paragraph 6.2 on page 72 for your reference, how did you quantify how common or rare it is for paramedics to see organophosphate poisoning?
Can you, 1 second, please?
Of course, please do find it. It's paragraph 6.2 on page 72. I've mentioned the slides, and it's the part after that that I'd like to ask you about the statistics that you mentioned anecdotally.
So I looked at some published literature, which particularly focused on the developed world. Yeah. And that was specifically around organophosphates. And then I asked a number of colleagues what their length of service was in the ambulance service. These were all senior colleagues in advanced practice roles, and asked whether they had seen an organophosphate overdose. So
first of all, just taking your first point about the literature focusing on the developing world, do we understand, and we've heard some reference to this, that organophosphates aren't used now in pesticides, so you don't really see in this country organophosphate poisoning, whereas in other developing countries there are more cases?
Yes.
And then you move on to say you asked some colleagues. Could you tell us what those figures were, please?
Do you have my reference? I can just absolutely.
Yes, 6.2 of page 72, and it's about halfway down the paragraph there. And you state, as stated above, in a 25-year career. That's the starting paragraph that I'm looking at. Do take time to look at.
So I asked 20 colleagues who just happened to be locked in a room with me at a critical care meeting what their length of experience was and whether they had seen an organophosphate overdose. The total length of experience in the group was 254 years. And none of those who I asked had seen an organophosphate case.
Were they colleagues in London?
They were London colleagues. I was then aware probably of the bias of doing that in an urban setting where there is not a lot of rural. So I asked 5 clinicians who work in a similar role in more rural areas of the country who had 52 years experience, and none of them had either seen a case.
And did that accord with your expectations?
That was absolutely my expectation.
A final point to make here. We heard from Dr. Haslam, the consultant responsible for the care of the Skripals, in March 2018. And I'll quote from his evidence. The reference for the transcript is day 8, 30th of October 24, page 190, line 21 to page 191, line 6. He said, paramedics aren't required to diagnose patients. They are there to keep them alive and support their physiology until they get to definitive care in a hospital. And then that's our job in the emergency department. The doctors are there, and doctors from other specialities, including my own. It's our job to help get to a definitive diagnosis, and that takes time. And I wouldn't expect paramedics to necessarily, they should have an open mind and treat potential options, but I wouldn't expect them to get to a definitive diagnosis. Do you, as an expert in pre-hospital care, agree with that?
I agree with the sentiment of it, but not the detail of it. There will be times that paramedics do reach a definitive diagnosis and will hand over a patient with a definitive diagnosis. That is not uncommon. But the principle that often that you are unable to get to a definitive diagnosis and you'll form a list of impressions. Sometimes that list is quite short. Sometimes that list is very long. But you will not be able to narrow it down. I agree with, and that's completely, in my view, completely correct.
And the priority being saving life as far as possible. Yes. Finally, on signs and symptoms, can I just ask you something about pinpoint pupils? If you go to your report at page 21, paragraph 3.17, this part quotes from the witness statement of Richard Miller, a critical care paramedic who attended Sturgess Skripal. And he says, at the bottom of the paragraph, the male paramedic from who he was taking over said that he had pinpoint pupils. I know that this could be a sign of an opiate overdose. So keeping that in mind, if you could then look further on at your report of page 26, paragraph 3.27, you quote there from the witness statement of Louise Cox, the other critical care paramedic, who's describing Julia Skripal in the back of the ambulance. And she said she had pinpoint pupils not reacting to any light and her gaze was fixed to the right. This was strange, as this would not fit in with a reaction to opiates. Could you just explain that to us?
So the pinpoint pupils or the meiosis would fit with an opioid overdose. The fixed gaze to one particular side where the pupils are moved off from the centre away does not fit with an opioid overdose in the main.
And while we're on the subject of pinpoint pupils, can I also refer you to page 47 of your report, paragraph 4.27. where you make further comment about pinpoint pupils, and if you could explain that to us.
So where a patient has a profound lack of oxygen, you will often see the pupils dilate and become bigger. Where a patient has taken opioids, you will see the effect of the opioids being the pinpoint pupils and the meiosis. Where the patient then becomes profoundly hypoxic or lack of oxygen and goes into cardiac arrest, often that dilation of the pupils due to lack of oxygen takes over, and you will see dilated pupils despite the patient having had an opioid cardiac arrest. This is quite nuanced, and this is not something I'd expect every paramedic to be able to work out. But we do see patients who have opioid cardiac arrest who have got dilated pupils.
Thank you. With those introductory points on signs and symptoms and medications and treatments, we're going to move to the clinical interactions with the Skripals, but we've already heard detailed evidence in this inquiry from Ian Parsons and Lisa Wood, the two paramedics who dealt with Yulia and Sergei Skripal. And we've also heard evidence from Alison McCourt and Helen Ord, the passers-by who came to their aid. So I don't propose to take you through the section of your report that deals with the pre-hospital clinical interactions in sequence, if you like.
If I remember, Miss Whitelaw, it was actually, I'm not complaining, it's actually Dr. Ord and Miss McCourt first, isn't it?
Oh yes, in terms of sequence.
And the paramedics next.
Yes.
Right.
Sorry, I was just covering the medical and then passers-by.
It's helpful. I just wanted
also happened to be medical.
Just wanted to be sure my recollection was right.
Yes, but sir, the point being, I won't go through all the detail of that we've heard, but rather, if I could take you, Mr. Faulkner, briefly to parts of your opinion, because of course it becomes relevant when we look at the response and treatment to Ms. Sturgess. So you set this out at pages 28 onwards, and starting with the 999 calls, we're broadly familiar with 999 calls, but you explain at page 11 of your report the way in which they are triaged. Can I take that shortly? Are they triaged by trained emergency medical dispatchers?
Yes.
Not clinicians, but trained individuals to deal with calls?
Yes.
And does SWAFT use MDPS, which is a commercially produced software suite?
MPDS, yeah.
MPDS, yes. Thank you. Using a series of reductive questions to triage the call?
Yes.
If we could go to your report, INQ 005942, page 12, and the table, please. Now, we heard evidence from Ian Parsons, the paramedic I've mentioned, and who first on scene to the Skripals, that this was an immediate call, and we also heard from Mark Marriott, the paramedic first on scene to Miss Sturgess. He was assigned as a category 1. So that's the category we're interested in at the moment. Could you explain then, looking at that table, the columns headed average response target and 90th percentile response?
So these are the commissioning targets for an ambulance service. So what the ambulance services are commissioned to deliver. It is worth noting that these are not targets for individual calls. They are a total target for an ambulance service across their entire calls of that triage category. So the 7-minute or the mean response time, so the ambulance service is expected to achieve a mean response to all of their category 1 calls of 7 minutes.
I mean an average?
An average, yes.
Yeah.
I was trying to be careful of the difference between mean and median. And a 90th percentile, so 9 out of 10 calls within 15 minutes.
And how is the call time calculated for category 1 calls?
So there is a set consistent measure of when the clock starts and actually when the clock finishes. And for a category 1 call, the clock starts at one of 3 time points, and it's whichever one of those is the earliest, the time the call is clinically triaged and coded, the time of a first resource being dispatched or assigned, or 30 seconds within the call connect if neither of the others have happened at that point. So there is a set definition of when the call starts, and the clock starts for an ambulance service, and the clock stops when the responding unit is within 200 metres of the call.
So if we can put that into practical action, if we may. Going firstly to the attendance on the Skripals, the first 999 call, INQ 000646. We've heard this was made at 16:19. I'll just wait for the document to come up. If we could make that larger, please. Do we see there call 1163749, the number of the call?
Yes.
We'll see a dispatch code 12D02. You explain that in your report. Can you confirm what that means?
So this is the disposition code from the triage system. The initial 2 numbers is and it's an old term, or the card set, or the condition that the triage is conducted down. So when the caller says somebody's fitting, historically you would have opened a set of cards to a fitting card, and you'd have then asked the questions on the fitting card. Clearly, in the 21st century, it's on computers. And then the next is a priority code, and then the final 2, or the 02, is a sub-code within the triage. So it is the disposition of the triage.
So the first bit, the card 12, that means a seizure or
Yes.
fitting. Yeah. And the next bit, D, that's the severity, and did that mean high severity?
Yeah, it's a high severity.
And the subcategory 2, did that relate to continuous multiple fitting?
It does, yes.
Did you consider that dispatch code appropriate in the circumstance?
Yes.
And then we'll see there that we have reported casualties 2, priority 1. The callback, I think that's a phone number redacted, is it, for data protection?
I would assume so.
Problem, patient fitting, does that mean PT patient?
Yeah, patient fitting.
Chief complaint, convulsions fitting. Location, Superdrug stores, 27 the Maltings. And at the top right-hand corner, do we have the call time, 4th of March 2018, 16:19:54?
Yes.
So the first call at 16:19. Now, although there were 2 subsequent calls, can you explain why the first is usually the primary call?
So it is the earlier call, and ambulance services triage onto the earlier call unless a latter call is of a higher priority. But this was a category 1, so this would have always been triaged to the earlier call.
So it's in your report. There were 2 subsequent 999 calls at 16:21 and 16:22, but the 16:19 is the one for the purposes of timings.
Yes.
Did you have any criticism to make about the triaging of the 3 calls?
No.
And we know that 2 rapid response vehicles, those of Ian Parsons and Lisa Wood, from whom we've heard, were assigned. If we could go to INQ 000646, page 2. We'll need to make this a little bit bigger, thank you. We heard that Lisa Wood's call sign was 671, so we're looking there for her being assigned to the call at 16:27:51. I think it's at the bottom, actually, of the page. Yeah, the very bottom. If we could make that a bit bigger. That on the far left-hand side, do you see there 671?
Yes.
And allocated, is that the same as assigned?
Yes. Yeah.
So we've got 16:27:51 at the bottom left-hand corner of that document, if we could highlight that. Thank you. And arrived on scene 16:31:28.
Yes.
And then if we could go over to page 3 of this document. And make the top bigger, we should see the same thing. I think Ian Parsons' call sign was 608.
Yes.
And do we see there assigned at 1628
Yes.
and arrived on scene 1632?
That might be my eyesight, 1631 or 1632.
I think it's 32.
32.
Well, you're right, it's not entirely clear. But I think... In your report, you say it was an 8-minute response time. So is that calculated from the time of the first 999 call to the first resource being assigned?
So it is the call start time on the first 999 call to the first resource arriving within 200 metres.
Right. So I think your conclusion was it falls just outside the 7-minute average response time, but well within the 90th centile.
Yes.
So what was your conclusion about the response time?
I'm not critical of the response time at all.
And even if targets are not specifically met, would you have criticism necessarily then?
No. By the nature of them being targets, there is an average target, which means calls will fall outside of it, and there is a 90th centile target, which again means that even an ambulance service that is achieving its response time targets will have individual calls that fall outside of those.
Dealing with the clinical interactions, your opinion of the clinical interactions with the Skripals, Sergei Skripal, first of all, we heard evidence that Lisa Wood, on attending Sergei Skripal, asked for P1, that's priority 1 backup. Is that an action that you thought was appropriate?
Yes.
And why was that?
You have a patient who is in extremis and one would quite easily describe as peri-arrest or about to have a cardiac arrest. And it is a way of saying you need backup and assistance immediately.
And you've already explained you've got no criticism of Lisa Wood's assessment that it might be an opiate overdose. And no criticism, again, you've dealt with of the decision to administer naloxone in those circumstances. Now, we now know that Carl Bulpitt administered atropine sulfate in error instead of a dose of naloxone in the ambulance, and you deal with this at paragraphs 3.44 and 3.45 of your report. If we could go to those, please, it's INQ 005942. Page 32. And if we could just enlarge 3.45, could you just explain that paragraph to us?
So the paragraph, atropine is primarily used in the treatment of symptomatic bradycardia, or slow heart rate that's presenting with symptoms. It's available in a variety of preparations, but and variety of strength ampules. So I don't know from the evidence I've reviewed what strength was carried in their drug bag. So I don't know how much atropine was administered. A standard dose in the ambulance service that I work for would be an ampule of 600 micrograms. But this is also the drug that is indicated in organophosphate poisoning, either accidentally or as a nerve agent. And therefore there is a chance, although this drug was administered in error and as a mistake, that it would have not harmed and may have actually provided some clinical benefit, which could have been life-saving.
Now, we heard evidence from Lisa Wood that she asked the nurse on scene to check that the drug she was about to administer was naloxone before she gave the first dose. And and I asked whether that was the usual procedure, and she said for any drugs that we administer, there's a two-step check. So you check yourself, and then you check you get somebody. Normally it's a colleague, but obviously I didn't have a colleague there. So she said I got the nurse who should be well versed in checking drugs to check the drug before I gave it, just to make sure it's the one I want to give. And so that, just for your reference, the transcript, it references day 8, 30th of October, page 97, line 7. Mr. Faulkner, would you expect paramedics or ambulance clinicians always to seek to perform that two-step check before administering drugs?
So the expectation is, yes, it should always be done. And it really doesn't matter who you do it with, because what you do is you hand them the ampule and say, read to me what it says on the ampule. So you don't say, that's naloxone or that's atropine. You say, what does that say it is? And you get them to read the ampule out. So it doesn't actually matter whether they know what it is or not. It also means that you don't bias what they say and they, oh yeah, it's morphine, and actually it's not. There will be times as an ambulance clinician where there is no one available to check a drug. That wasn't the case in Salisbury. And therefore, I would be critical that a drug check wasn't done.
But we've heard here, of course, that the accidental administration in this particular instance was not only unlikely to have harmed Mr. Skripal, but as you say, it may well have improved his condition. And in your report, you indicate it could well have been a life-saving intervention, albeit an error.
Yes.
Moving to paragraph 3.46 of your report, you do make some criticism of the decision by the critical care paramedics to administer diazepam emulsion, the diazomols that you've spoken of, to Sergei Skripal. Could you just tell us about that?
So the indication for ambulance clinicians in routine frontline practice is diazepam has a number of indications, one being continual status seizures, the other being symptomatic cocaine toxicity. My understanding was the reason it was administered was the ambulance clinicians were of the view on their assessment that Mr. Skripal had trismus or a locked jaw, and it was to aid with ventilation. That's not standard practice, but these were paramedics working in a specialist role. Benzodiazepines are used, and the group of drugs that diazepam belongs to or belongs within are used when patients have trismus or a locked jaw. I think my view is that it's quite a large dose of diazomols for a patient with a locked jaw. I can understand why it was given. If there were specific SOPs or policies to allow that, I would be supportive of it, but it does seem quite a large dose. But I can also understand a very experienced ambulance clinician making a clinical judgment with a patient in extremis.
So is it fair to summarise that then, that it's not your view wouldn't have been to use it, but there may be circumstances, in particular the experience of the ambulance personnel, that meant that that was something they felt they ought to do? Yes,
and I think it would be fair. I wouldn't be using it at the doses that it was used at.
And what's the risk of that?
So it is a respiratory depressant and a muscle relaxant, so it can actually worsen the airway by muscle relaxation. I bet that's what you're trying to do. And also it can depress respiration and level of consciousness.
That's dealt with the your opinions, I think, as regards the response to Sergei Skripal. In terms of Yulia Skripal, we've heard evidence from multiple witnesses that her condition was much more serious than Sergei's at the bench. As you recognised in your report, she was completely unresponsive and had significant bronchuria. If we could just go to your conclusion as regards Yulia, that's INQ 005942, page 33, and paragraph 3.50. You say there, on consideration, I have no criticism overall in the care of Ms. Skripal, and my opinion on the medications used to manage her condition is the same as that of Mr. Skripal. It should be noted that Ms. Skripal was given a high dose of naloxone and this had no effect on her. This may have highlighted to the ambulance clinicians that the presentation may not have been opiate overdose. However, on the whole, I'm not critical of any failure to consider organophosphate poisoning. Is that a conclusion you stand by now? Is there anything you'd like to add to that?
No, not at all. I think there is when you look at this with the benefit of hindsight, you would say, oh, perhaps they should have been responding to the naloxone. But when you think, and when you look at it with the patient in front of you, and you look at it there, probably what the likely explanation was is this will be really potent opioid. I may just need to continue to give high doses of naloxone to get a response.
In terms of the opportunity to consider alternatives to opiate overdose, in the concluding section of your report regarding the incident in March 2019, and I'm looking at your page 34 now, paragraph 3.57, you say you carefully considered the presentation of Mr. and Ms. Skripal and whether there was any reasonable opportunity to consider any alternative cause for their presentation. I'd like to ask you to explain your conclusions in this regard. Firstly, can you comment on the relevance or otherwise of their appearance, age, dress in making a clinical assessment?
So I think we have to be very careful as ambulance clinicians that you do not bias your clinical assessment by what a patient looks like. I've been to opioid overdoses who are in a poor state or unkempt in appearance. I've been to opioid overdoses in some incredibly well-dressed patients in incredibly well-dressed settings. You've got to be really careful that you're not biasing an assessment based on somebody's appearance, and you're making an assessment based on the symptoms they are presenting with and the signs that they're showing.
And next, how relevant is it that there were two patients at the same time?
So it highlights the concern, but it's not unusual to see in opioid overdoses two patients who may have bought drugs from the same source to have bought a particularly strong batch of drugs. There are other substances, I bet, that don't normally present with pinpoint pupils that you see group exposure to, one of which is spice. So it doesn't really add a lot that there were two people. It's not unusual. I've seen plenty of drug overdoses where two people have taken the same batch of heroin and you turn up to find two patients not breathing.
Well, can the taking of drugs, like the taking of lots of other intoxicants, be a social event?
Yes.
Right.
Finally, in terms of the Skripals, we've looked at the signs and symptoms of opiate overdose as compared to organophosphates. Could I ask you which elements fit with the drug overdose hypothesis and which did not? And you address this at paragraph 3.58, page 35.
So the decreasing level of consciousness, the meiosis, all fit along with a level of respiratory abnormality with the kind of toxidrome one would expect from opioids. There are elements that fit less well. Airway secretions, I bet you can see airway secretions as we've discussed in opioids. Sweating and low heart rate probably fit less well. But again, in somebody who's got profound levels, lack of oxygen and profound central hypoxia, you will see patients with a low heart rate. So there are things that are very classic of opioids. There are things that are less classic, but are also explainable with an opioid overdose.
An extract was put to Dr. Cockcroft of the expert reports of Dr. Saw and Nolan, from whom we'll hear tomorrow, which describes organophosphate poisoning as a wet opioid toxidrome because of the aspects of secretions and sweating. Is that a description that makes sense to you in light of what you've just said?
Yes, but I would just clarify that I've seen some pretty wet opioid overdoses too. If
If we could go to your report, INQ 005942, page 35 and paragraph 3.58, just to conclude this section of your evidence. As at March 2018, your conclusion was, as regards, I should say, for a paramedic working in general pre-hospital care to form an impression of a cholinergic toxidrome in such a circumstance was not reasonable, and I would have expected nearly every paramedic I've worked with, including myself, to have formed an initial impression of an opioid toxidrome. So, in short, is it your expert opinion that there could be no criticism of the paramedics in March 2018 not to recognise organophosphate poisoning, let alone nerve agent poisoning?
That's completely correct.
So that concludes that tranche of the evidence. I wonder if it's time for a break.
Which is a convenient point of break, isn't it?
Thank you.
Mr Faulkner, I'm going to ask you to wait, please, not there, but come back at 3:15. You're in the middle of your evidence. Keep your counsel in the meantime, please. 3:15, please.
So, Mr. Faulkner, I said I'd come back to the period in the post-Skripal period of the training and guidance issued. We've heard that the due-date SWAFT guidance was recirculated post the Skripal poisonings. Would you have expected SWAFT paramedics to have received internal training on the signs and symptoms of nerve agent poisoning after the Skripal incident?
So not specifically.
What about, we've heard, and I'll come to look at this in more detail again with you, about the overlap or crossover not only between the symptoms of nerve agent poisoning on the one hand and organophosphate poisoning on the other, and but also opiate overdose and other presentations. In your opinion, after the Skripal poisoning, ought paramedics to have received specific training about that?
I don't think so specifically, noting that it is really difficult to differentiate the two in the real-world clinical practice.
Would it apply in other circumstances of different presentations that there would be overlap between different conditions?
Absolutely.
So is what you're saying that that training that paramedics get generally about how to make clinical assessments would be sufficient?
I think so, yes.
Now, we heard from Mr. Darch that a number of documents were also circulated in this post-Skripal period. If we could go to one of those, INQ 000659, is that one you recognise, a Public Health England document?
So I recognise it from preparation for this. I don't believe I saw it at the time in my own clinical practice.
So this is diagnosis and early management in organophosphate chemical incidents. PHE advice, as we understand it, for emergency departments. And we've seen similar documents aimed at GPs and NHS pathway documents for call handlers. Do you think there ought to have been specific guidance documents for paramedics beyond the national JR Calc guidelines and the local duodope guidelines we've seen circulated?
No, and my rationale for that is actually when you look at these documents, much of the contents of them is already within JR Calc.
Can you just remind me what the date of this one was, Miss Whitelaw? It's in the gap, is it, between Salisbury and Ainsbury?
Oh, in terms of when it was circulated?
Yes.
I believe so. And I will double check it.
Thank you.
On the date for you, because I don't have that to
Well,
hand.
I'm sure we can find it.
Thank you, yes, certainly. Sorry, so you were saying that your rationale was that the content is largely within the JR Calc guidelines.
Yes.
So is there advantage to having central national guidelines which set out the signs and symptoms rather than lots of different documents?
Absolutely. Very rarely in my management ambulance clinicians have I ever solved a problem by providing them with another sheet of paper. Actually, it's about having consistent guidelines that clinicians know where to look when beside a patient, and actually often you just increase confusion when you have lots of additional bits of paper.
And we've heard there is the CRESS algorithm, the flowchart now within the national guidance.
Yes.
So that deals with documents. What about training? Do you think there ought to have been any training provided? So in person perhaps, or by other means?
So I thought really hard about this and about how you would train and what you would deliver. And it is the theoretical, this is what the toxidrome looks like. This is a refresher on what geodote does and how it's administered. But beyond that, I'm really unsure how you would deliver meaningful training to very significant numbers of clinicians in an ambulance service with any hope that that's retained and applied consistently. And actually, I think some of the time there is that refresh of what's in JR Calc might be as good as you manage in a classroom face-to-face session.
What about shared experiences of those who were actually involved, those paramedics? Is that something that you would have expected?
I think how you do that meaningfully across a huge ambulance service with a massive geographical region, you can consider local training, but what's local? Is it just in Salisbury? Is it Salisbury and the surrounding areas? Is it anywhere that individuals may have passed through with agents? It's really challenging to do. And to make personal experiences work really well, you've got to have people tell that personal experience and be able to answer questions about it.
Thank you. If we could come now to the response to Dawn Sturgess's collapse. You set out at page 37 the timings, in case you want to have those to hand. We heard evidence from the paramedics in Salisbury that the 999 call was at 10:14:25. The transcript reference for your notes, sir, is day 4, 17th of October, pages 128 to 134. And it's also within the call logs that are set out very clearly in the report at page 37, those timings and references. Did you take your timings from the ambulance call log?
Yes.
So you'll recall reference to the Kerry Law's sudden death report yesterday, recording it as 10:11, but we have 10:14 as the time of the 999 call. And that's the time, Mr. Faulkner, you record in your report. We heard, and you've explained, the call received an initial coding of category 1, which is consistent with the evidence we've heard from the attending paramedics. What was the clock start time for this response? And to help you, your report at page 38, paragraph 4.10 should have the timings.
10:16.
Mark Marriott, the attending paramedics vehicle call sign 303, was allocated at 10:16:04, and he was recorded as being on scene 199 metres away at 10:23:35. That's a 7-minute time. Is that the clock start and finish?
Stop time, yes. Yeah.
And so what was your conclusion as to the response time to the 999?
I have no criticism of the response time.
Did it fall both within the average response target and the 90th centile response
Yes.
target? The call was initially given as fitting, and code 12D02, that's the same code as for the Skripals, is that
Yes.
correct? So to remind ourselves, did that mean seizure, high severity, and continuous or multiple fitting?
Yes.
And what was your view of the appropriateness of the initial coding?
I think that was appropriate from the information provided.
But in the case of Dawn Sturgess, did the code change to 09D01?
Yes.
And what did that reflect?
So that reflects that the triage system has detected a change to cardiac arrest, and the call has been reclassified as a cardiac arrest. 9 being cardiac arrest, D being high priority, and 01 being the subset for cardiac arrest.
Now, according to your timings, which you set out on page 37, the recoding was at 10:23.
Yes.
And we know that 10:29, the cardiac arrest was confirmed by the attending paramedic.
Yes.
Do we know how it came about that that first recoding occurred?
So it will be from information provided within the 999 call, which will either be that the caller reports an absence of breathing or an absence of normal breathing. So it will either be that the caller has said the patient stopped breathing, or they will said something that means that their breathing is now significantly abnormal. And MPDS, the triage system, uses a breathing detector where you ask the caller to tell you every time the patient takes a breath. And if it's below a certain rate, that would trigger a cardiac arrest recode.
So from the timings, it looks as if the call was 10:14, so Dawn Sturgess has collapsed at that point.
Yes.
By 10:23, cardiac arrest is certainly suspected.
Yes.
and at 10:29 that's confirmed.
Yes.
So it's possible, therefore, that the cardiac arrest could have occurred some 6 minutes before the paramedic
Yes.
confirmed it.
It's also, from my experience, highly likely that the cardiac arrest occurs before the caller recognises it, because the natural human reaction, unless you're used to looking at people who stop breathing, is that there's a natural pause before actually somebody reports and recognises it. So it could well be the cardiac arrest was in the minutes prior to 10:23.
And did you...
Or even, I suppose, before the 10:14 call. Do we know? Do we know?
So we know that the caller, who was Charlie Rowley,
Yes.
reported fitting.
I see.
Yep. Fitting can be a symptom of a cerebral anoxia, and you do see cardiac arrest calls where the patient presents as a seizure.
Right.
But equally, you can have seizures that then go on to cardiac arrest. So it may well have been, but equally it may not have been, sir.
Thank you.
Did you consider the change of coding appropriate?
Yes.
And why was that?
Once you have information around a patient who either has absent breathing or absence of normal breathing, it's really key that that information is updated. So that helps the ambulance clinicians understand what they're going to when they're being dispatched. And it means that the call is being triaged. It doesn't change the category, but it means it's being triaged as accurately as it can.
Thank you. That was going to be my next question. So, you note, and we've heard from Mark Marriott, that he did have some difficulty finding the address due to the estate being a new build development. Is that a problem with which you're familiar?
It's a problem that occurs probably 3 times a shift when I'm at work with my map reading ability and new developments.
He did indicate that although that was a SWAFT system issue at the time, now they'll often get information from What 3 Words and Google Maps as well, but obviously more difficult when you're single crewed to
Yes,
be able to access other
and
information.
And simply put, it is close to impossible for any emergency service to keep up with new developments and mapping.
And in any event, the problem wasn't sufficient for you to criticise the response time in this case?
No.
Now, we heard from Mark Marriott and from Keith Coomer, the lead paramedic in the ambulance, which arrived after Dawn Sturgess had suffered cardiac arrest that was confirmed by Mark Marriott. So I don't, similarly to the Skripals, I don't propose to go through all of the sequence of events with you, but I'm going to ask you, first of all, to explain the 4 cardiac rhythms which may be seen in cardiac arrest. So for that, could we go to INQ 005942, thank you, page 41, and the diagram there. First of all, does the defibrillator tell you which cardiac rhythm is present?
So it displays the cardiac rhythm, and then you interpret the cardiac rhythm from the display, or you can have it in an automatic mode where it also will just advise you what it wants to do.
I understand some of them have a talking function. Is
Yes.
that all of them, or?
So if you got a defibrillator off the wall here, it would have a talking function because it's an automatic defibrillator. The ones in the ambulance service normally have an automatic and a manual mode, and it's a choice of clinician or the ambulance service about which mode it's in.
And does it also tell clinicians when the rhythm is a shockable rhythm?
Yes, when it's in automatic mode.
So do you just want to take us through each of those briefly to explain them?
So the step before that is a cardiac arrest is a loss of detectable cardiac output. So in essence, you can no longer feel a pulse, which for most people is indicated by an absence of normal breathing. When your heart is no longer beating to create a pulse or blood flow, there are 4 potential rhythms. The first is that the heart goes into an abnormal quivering rhythm electrically and often mechanically, and if you look at the heart, it will sit there and quiver. Rather than beating, it actually just sits there and quivers. That's called fibrillation or ventricular fibrillation. You can get a very rapid heartbeat coming from the chambers at the bottom of the heart, which are your ventricles, and you have a very rapid heartbeat. That heartbeat is often so rapid that it doesn't allow the heart time to fill with blood, and therefore the heart can't create flow because it's not filling. That is called ventricular tachycardia. Both ventricular fibrillation and ventricular tachycardia are potentially amenable to a defibrillation shock. So you apply electric shock across the chest from a defibrillator. Commonly, everyone describes defibrillators as restarting the heart. In fact, what they do is stop the aberrant or abnormal rhythm and allow the heart's normal pacemaker to take over. You then have the concept of pulseless electrical activity, where you have an organised cardiac electrical activity, but that does not correspond with a cardiac output or a pulse. And the easy way to describe this is if somebody bleeds to death, they have no blood volume, but their heart is electrically conducting, but they have no pulse because there's nothing for the heart to squeeze out when it beats. You can see pulseless electrical activity from many conditions, but loss of blood is an easy one to explain to people, where you have organised electrical activity, but no corresponding cardiac output. And then finally, you have asystole, which is the absence of any detectable cardiac electrical activity, so in essence, a flat line trace on the monitor. Asystole is the terminal rhythm of all cardiac arrests that are untreated and unresuscitated. Everyone will end up in asystole. So even if you present in ventricular fibrillation, nothing occurs, that rhythm will deteriorate to asystole. If you start in PA, it will deteriorate. But you do see cardiac arrests where the patient presents in de novo asystole as a presenting rhythm for their cardiac arrest. Asystole and pulseless electrical activity are not amenable to a defibrillator shock.
Thank you. We've heard that Dawn Sturgess's cardiac rhythm was initially described by Mark Marriott as asystole, so that's the top right-hand corner diagram. With reference to page 79 and paragraph 6.8 of your report, are you able to assist with the survival rates for out-of-hospital asystole?
Yes. So the service that I work in has a register of all cardiac arrests, and we follow those patients up where we can at 30 days. And the 30-day survival of asystole, so this is patients who present in asystole, so their first detectable rhythm by the ambulance clinician is asystole, has a survival to discharge rate of 1.3% and a slightly higher, but not much higher, survival to 30-day rate.
And you issue the caveat in that paragraph that that figure is simply based on discharge from hospital, so is not an indication of neurologically intact survivors.
Sadly not. In fact, when you look at neurologically intact, it is lower still. It's also probably worth saying that figure is a population figure. So it is across the entire population. In adults, the asystole survival is worse than in children, we believe. So actually, in adults, the asystole figure is even worse than 1.3%.
There came a point, we understand it to have been 10:51 from the records, that when the defibrillator indicated that Dawn Sturgess's heart was shockable, and a shock was delivered and a return of spontaneous circulation achieved, you indicate in your report by reference to the Easy Task report that this was due to Dawn Sturgess being in ventricular fibrillation. Is that the disorganised electrical signal from multiple areas of the ventricles which restricts normal cardiac contraction?
Yes.
If we could go to the Easy Task report, INQ 000607, page 1. Is this an air ambulance report?
Yes.
And we see the names Fred Thompson and Keith Mills at the top.
Yes.
Yes, on the left of the vehicle model. And then page 2 of this report. Do we see the notes there, which include initial asystole, full ALS,
Advanced life support,
went into VF, that's the ventricular,
fibrillation,
and ORIS, that's the ROSC, the return of
spontaneous circulation.
Yes, and we see the timings are marked there at 10:55, but I think you've indicated in your report there were a few discrepancies, this having been completed later.
Yes, that's not uncommon in ambulance reports, and it's fairly common to see timings out by a few minutes.
And so in terms of how the air ambulance crew would know that she had been in VF as opposed to VT, was that because it was shown on the defibrillator?
It's likely by that stage that they would have had the monitor in a manual mode and were looking and observing the rhythms themselves. Just for completeness, patients in cardiac arrest fairly regularly change rhythm. It's the aim of resuscitation of somebody in asystole to get them out of asystole. They will often go into another rhythm, and you fairly frequently see patients who have had large doses of adrenaline in cardiac arrest, then go into a ventricular fibrillation and then be shocked. That's different from what their presenting rhythm is, or their de novo rhythm.
I was going to ask you that. So is it the case that the resuscitation effort caused the ventricular fibrillation?
I'm absolutely certain of that.
Thank you. If we could now move to medications and treatment given or not given to Dawn Sturgess, and beginning with adrenaline, which you deal with at page 44, paragraph 4.22. During cardiac arrest, Dawn Sturgess was given, I think, 3 doses of adrenaline.
Yes.
What was the purpose of that?
So the purpose of adrenaline is in order to gain a return of spontaneous circulation. Increases peripheral resistance, therefore aims to increase cardiac filling. It also increases cardiac electrical activity and it aims to stimulate the heart into gaining ROSC.
And is it part of normal life support?
Yes, for a patient in a non-shockable rhythm, adrenaline is administered every 3 to 5 minutes from the moment vascular access is achieved.
Can it also be given after ROSC to maintain cardiac?
Yes, but at a lower dose.
To what extent did you consider it reasonable to administer adrenaline, both initially and after post-ROSC?
So adrenaline is a core tenet currently of advanced life support and was completely appropriate and exactly what would have been expected. I'd have been highly critical if it wasn't administered. And in a post-ROSC patient who has hypotension, so low blood pressure, therefore indicating a low cardiac output, it's absolutely appropriate to administer small boluses of adrenaline to support that cardiac output. And I would expect in many of the cardiac arrests I attend who gain ROSC, I have to support their cardiac output routinely with small boluses of adrenaline.
So is that the adrenaline stimulating both the blood pressure and the heart rate?
Yes. It also increases cardiac blood flow by increasing constriction of blood vessels.
And to what extent is and was at the time the use of adrenaline in cardiac arrest and post-ROSC covered by the JR Calc guidelines? So
adrenaline in cardiac arrest was routine both in the National Advanced Life Support Guidelines and in the JR Calc guidelines. Adrenaline post-ROSC was not in JR Calc, but many services had processes for doing that, and today it is in JR Calc. But prior to that, it was standard practice, and certainly it's been standard practice in the service I've worked in for over 10 years.
So that's adrenaline. Moving now to atropine. Was and is atropine recommended for use in cardiac arrest?
No.
Was it once,
Yes,
but not in 2018?
certainly not in 2018.
So is that because although atropine can be used to increase heart rate, the mainstay treatment for cardiac arrest is adrenaline?
Yes.
Naloxone. Was Dawn Sturgess given naloxone?
I believe so.
I think that's right. And if we deal, you deal with it, I think at paragraph, page 46. Yes, paragraph 4.26.
Yes.
So similar to Mr. and Ms. Skripal, I note that Ms. Sturgess was administered naloxone due to consideration of potential for opiate overdose. So in simple terms, the drug overdose suspected in the same way as the Skripals,
Yes.
and so that administration. We've seen in the notes the brand name Narcan used, which we also heard from paramedics attending the Skripals. Can you explain the extent to which you consider this reasonable and why? And if you need to refer to your report, it's page 52, paragraphs 4.44.
So I'm not critical of the decision to administer naloxone. The management of cardiac arrest is in essence twofold. One is which is supporting the cardiac output. The second is looking for a reversible cause of that cardiac arrest. So CPR is around, in the main, temporisation, and then you're looking for something you can potentially reverse. As we spoke about earlier, naloxone is a relatively safe drug. If you've got signs and symptoms that might potentially be opioid is not an uncommon presentation, and it would be completely reasonable to administer naloxone. The evidence for naloxone in cardiac arrest is actually quite limited, but I would not be critical of actually anyone administering it.
I think you refer to there having been reference to the pinpoint pupils, meiosis.
Yes.
And although you've indicated in your evidence that that can be a sign in a number of presentations, would it also be most common in pre-hospital care for opiate overdose?
I think it would be probably the one that most paramedics were most familiar with by some way.
So would that be a trigger to consider and administer
Yes.
naloxone?
Yeah.
And just to recap, you touched upon this earlier, but the difference between meiosis, the pinpoint pupils, seen in cardiac arrest and seen in organophosphate poisoning is that, I think you said earlier, that meiosis will generally wear off as the arrest progresses.
Yes, so as the patient becomes more and more profoundly lacking of oxygen, you'll often see the pupils dilate. You don't see the same in cardiac arrest from organophosphates or nerve agents.
But is that a subtle?
Very subtle, and again, I wouldn't expect many paramedics to be aware of that.
This morning, Professor Rutty indicated that both at the hospital and in for the part of the post-mortem, the possibility was considered of a stroke or an intracranial bleed being the cause of the collapse. Now, we know that Charlie Rowley said that Dawn Sturgess had complained of a headache before she collapsed. Are you familiar with a headache being the first sign of brainstem stroke or intracranial bleeding?
Yes.
So is that something you'd expect paramedics might consider?
Yeah, I think it would be up there with a list of differential diagnoses.
And can meiosis be seen where a brain injury is the cause of cardiac arrest?
Yes.
How common is that compared to meiosis being seen in drug overdose or organophosphate poisoning?
So most paramedics, I would expect, will have seen patients with an opioid overdose and pinpoint pupils. I suspect many paramedics will occasionally encounter somebody with a significant intracranial hemorrhage that causes pinpoint pupils, but it's much rarer and probably less commonly known.
Thank you. We're just pausing to take a note. By the time the air ambulance, Fred Thompson and Keith Mills, attended at about 11:05, Dawn Sturgess was being treated with an eye gel and bag valve mask, and we'll recall the picture of the eye gel that we saw earlier. In your opinion, ought mechanical ventilation to have been considered or used?
So mechanical ventilation was occurring, in essence, that she was receiving artificial ventilation by a bag and mask, supported with an eye gel. That is mechanical ventilation. It's just the mechanics of it are a human squeezing a bag rather than the machine ventilating.
So a machine would have made
no difference.
And I think that's the same as the management for Julia Skripal, is that correct?
Yes,
But the difference being that Julia Skripal didn't enter cardiac arrest.
that's correct.
And so the defibrillator and the adrenaline weren't needed in her case, but they were in Dawn Sturgess's.
That's correct.
Now, the eye gel was swapped in the ambulance for an endotracheal tube. And you indicate in your report, and I'm looking at page 48, paragraph 4.32, that this is somewhat controversial, but you would not be overly critical of it. Could you just explain that?
So intubation is where a tube is placed through the vocal cords into the top of the windpipe or trachea to allow artificial ventilation, and in most adults is secured in the windpipe with an inflatable cuff. It's done under instrumentation of the airway. Outside of cardiac arrest, patients will normally be given drugs to facilitate that. But there is a group of patients who are so obtunded they do not need drugs and they are so unconscious. There is some controversy around intubation of the post-ROSC patient without drugs, so a patient who has just had a cardiac arrest who has no airway tone. It is controversial. It is done fairly frequently by paramedics, particularly paramedics working in critical care. I've done it in my own practice. It is a balance of risk. That risk is made increased by if there was significant pulmonary secretions or edema, that might tip one towards doing it. But there will be people who will be critical of it. Normally the people who are critical of it are those who have an enhanced scope of practice, who have the ability to give drugs. My view is for paramedics, it is often in those first minutes following cardiac arrest appropriate, and I would not be overly critical of it. And it is practice that I have undertaken myself.
And indeed, I think at this stage it happened in the ambulance.
Yes.
So not in the immediate period after ROSC. Could I just ask you about hyoscine hydrobromide? What is that? Is it a pre-hospital treatment for nerve agent poisoning?
So it's not a pre-hospital treatment for nerve agent poisoning, and it's not routinely carried by many ambulance services as a frontline paramedic drug.
And what is it?
It's an anti-secretion medication.
So you wouldn't have expected it to have been either carried or administered in this case?
No, some critical care teams carry it normally for management of patients at end-of-life care and patients who are actively dying. But no, it's not. It's far from routine, and it would be a drug I would expect many paramedics not to be familiar with.
And finally, diazepam. The indications you set out in your report for the use of diazepam, which we've touched upon, are fits lasting longer than 5 minutes and still fitting, repeated fits, not secondary to an uncorrected hypoxia or hypoglycemic episode, status epilepticus,
So continual fits is another way of describing continual fits.
and eclamptic fits.
So fits during pregnancy.
So was Miss Sturgess presenting with any of those
No.
features? So am I right in deducing from that that diazepam wouldn't have been indicated in your opinion?
Yeah, so the other indication in the ambulance service guidelines is symptomatic cocaine toxicity, which again she wasn't presenting with. That's somebody who's taken cocaine, who's got chest pain, tachycardia or hypertension, so high blood pressure.
Does that cover the medications that were either appropriate to deliver or weren't appropriate in
For
her
completeness,
case?
she was also administered oxygen, which was completely appropriate and as part of her resuscitation.
Thank you. Moving then to your opinion regarding the clinical encounter with Dawn Sturgess, and I'm at page 51, paragraph 4.40. What did you conclude about whether Dawn Sturgess was in cardiac arrest when the first paramedic arrived?
She was in asystole, is reported she was asystole on the monitor. That is unequivocally associated with cardiac arrest. She was in cardiac arrest on arrival of the first paramedic.
And by reference to page 50, paragraph 4.41, if you need to, what were your conclusions regarding the appropriateness of treatment given to Dawn Sturgess on attendance at the cardiac arrest?
Dawn Sturgess had an advanced life support resuscitation, which I view was completely appropriate. Drugs were administered in line with guidance and her ROSC was managed, and on my review was managed appropriately.
Just to take you back to the first part of that, the advanced life support, I think when the first paramedic arrived, that was basic life support in the first instance because he was solo. Is that
Absolutely. And I would be highly critical if a paramedic on their own arrived and started doing advanced life support before doing the basic life support.
Start with the basic, which is CPR and getting defibrillation ready.
Yeah, so basic life support is chest compressions, artificial ventilations, which initially will be with a bag and mask, so just a mask that goes on the face. Attachment to a defibrillator, which is often now described as intermediate life support, and then moving on to more advanced airways and drugs in cardiac arrest or advanced life support.
Then the advanced life support, could we go to INQ 005942? This is your appendix 1 of your report. And if we could enlarge that a bit, could you just take us through that and confirm whether or not this was the advanced life support process that was followed in Dawn Sturgess's case?
So this is a 2021 version, but there was no changes in the preceding versions, which in essence is the management, and it is effectively, once you get into advanced life support, 2-minute cycles of analyse the cardiac rhythm, assess whether a shock is indicated, and then on every other cycle, on a non-shockable, to administer adrenaline.
You said the 20 or 21 version, that's of the JR CAP.
So this is actually the UK Resuscitation Council
thank you.
guidance. And then you'll see at the bottom of it the consideration of reversible causes, which we discussed earlier.
Yes, can you just put, so that's the second column, if we can make that a bit bigger at the bottom. So you said we discussed earlier, just to confirm what you mean by that.
So as well as trying to restart the heart and providing the temporisation, you're then thinking about what has caused the patient to go into cardiac arrest and is that potentially reversible? And the UK Resuscitation Council and the international guidelines produces a list of 4 H's and 4 T's, and they are common things that are reversible in a cardiac arrest: low oxygen, hypoxia, low circulating fluid volume, hypovolemia, high or low abnormal metabolic, thrombus, so blood clots either in the coronary blood vessels or the pulmonary blood vessels, tension pneumothorax, which is a collapsed lung which is under pressure, cardiac tamponade, so fluid around the heart, restricting the heart, and toxins.
So which of those are relevant in this case to Dawn's presentation?
So the one that's specifically relevant is toxins, and you saw the ambulance clinicians attempting to address that with the administration of naloxone.
That's what I was going to ask. And then if we can take that down now, I'm going to move to ask you about whether they should have considered nerve agent poisoning. Now, we've looked at the signs and symptoms of opiate overdose, organophosphate poisoning, and the overlap. And I think you've already indicated in your evidence that there's considerable crossover.
Yes.
Now, one of the features that we saw was hypersalivation or secretions in potential organophosphate poisoning. Dawn Sturgess did present with that symptom on ROSC, is that correct?
Yes.
But can hypersalivation result from cardiac arrest in circumstances other than organophosphate poisoning?
Absolutely, and is relatively common.
Could you explain the types of circumstances?
So you will see airway secretions fairly regularly in cardiac arrest, but you will also see patients who have pulmonary edema, so fluid coming up from the lungs. That's not possible to differentiate. And you will see pulmonary edema in cardiac arrest generally. You will see pulmonary edema specifically in cardiac arrest from heroin. You'll see pulmonary edema in cardiac arrest, and there are neurogenic causes, so from people who've had brain bleeds. So there's lots of things that will give you respiratory secretions.
So if the paramedics had arrived before Dawn Sturgess had gone into cardiac arrest and seen hypersalivation, is it more possible that it might have alerted them to?
I think it's more possible. Once a patient enters cardiac arrest, your ability to gain that additional history and those additional signs and symptoms are considerably reduced, because you're now looking at a patient who is not breathing, doesn't have a pulse. So all of those other classic signs and symptoms are starting to reduce. So it's even more challenging to detect it once the patient's in cardiac arrest. And there is no single thing that gives you that clue.
And is that the overriding difference between the presentations of the Skripals and Charlie Rowley, who we'll come to, and Dawn Sturgess?
Yes, that they did not, the Skripals or Charlie Rowley did not present in cardiac arrest. So the ambulance clinicians would have had more information available to them.
So we've looked at meiosis and excessive secretions. Was there any other reason, I'm at page 77 now of your report, was there any other reason you could see from the evidence for a paramedic to suspect nerve agent poisoning on attendance at Dawn Sturgess? I'm on the third paragraph down of your page 77.
So the signs that Dawn Sturgess presented with might not be classical opioid overdose, but I make no criticism of the ambulance clinicians in terms of their view that this was opioid. I think it is incredibly challenging to get to the point of organophosphate or nerve agent at that point. And I'm not critical that they treated her as an opioid cardiac arrest. And much of the management in cardiac arrest is focusing on gaining that ROSC, as well as considering the reversal cause. But much of actually what you're doing is just trying to get the heart restarted through consistent measures.
In coming to that view, and you say at your page 77, I cannot in any way criticise any ambulance clinician, either in the management of Ms Sturgess or any other patient involved in these incidents, for not suspecting nerve agent poisoning. To what extent did you take into account that, although it's incredibly rare, there had, of course, been a nerve agent poisoning in Salisbury, not too far away, and only a few months previously?
So I took it into account, I considered it. But yes, it wasn't too far away, but it was distant from Salisbury. By a number of miles, it was local but distant. It was a very different circumstance. So I'm not overtly critical, and I did consider that when forming my conclusion.
And similarly, informing your conclusion, to what extent did you take into account the fact that guidance had been distributed to paramedics in between Salisbury and Amesbury, such that it might be said they ought to have increased awareness of the presentation of nerve agent poisoning?
So again, I considered that and considered the guidance I'd seen, and I don't think that changes my view. I would not be that critical. I would not be critical.
Moving then to the treatment if nerve agent had been suspected. If the ambulance clinicians had suspected nerve agent poisoning and Dawn Sturgess had not been in cardiac arrest, what treatment would you expect?
So I'd have expected I'd expected safety precautions to be considered, donning of personal protective equipment. I'd have expected oxygen administration, and I would have expected, if they suspected nerve agent, duodote to have been administered.
Now, we know she was in cardiac arrest. You heard, I believe, the evidence of Professor Rutty this morning about there being no indication that duodote should be used in cardiac arrest. Do you agree with that?
Yes.
Do all ambulances and RRVs carry duodote?
All ambulances and RRVs should carry it. I wouldn't want to say that they all do carry it.
So, reasonable not to consider duodote prior to when she was in cardiac arrest, even had they seen signs of organophosphate poisoning or suspected it. What about when she was in ROSC?
So you could have administered it in ROSC. I'm not sure how much it would have got into her circulation. Clearly, when somebody's in cardiac arrest, their blood flow to their muscles is reduced. Therefore, giving an intramuscular injection in cardiac arrest probably has limited efficacy. In somebody who's profoundly shocked with low cardiac output in ROSC, you would imagine limited absorption. That said, I'm not critical even in ROSC that they didn't suspect organophosphate or nerve agent. Therefore, I'm not critical that it wasn't administered in ROSC.
So just sticking with the ROSC position at the moment, I think what you're indicating is there's a possibility that even had it been used, it might not have been absorbed and worked because of the muscles. Is that correct?
Yes, or the muscle perfusion.
So I think you, in your report, you agree with Professor Rutty's opinion expressed in one of his statements, the 4496, which is the 21st of November 19. You address this at page 79 of your report, that there may have been some benefit if they'd identified nerve agent and if it had been administered in ROSC.
Yes.
But you're also saying that there may not have been benefit because of the potential lack of absorption.
Yeah, and there would have certainly been reduced benefit.
And we heard Professor Rutty say about whether he could, I can't remember the exact phrase, but in terms of it potentially making no material difference.
Yes.
Do you agree with that?
Yes, as far as my expertise allows me.
Because I think, and the phrase we used, the damage was potentially already done because of the period of cardiac arrest, and we've heard the sequence of events leading to hypoxic brain injury.
I think when you look at the time of ROSC, the period of what one would describe as no flow, so a period where there was no cardiac output or limited cardiac output, and then a period of low flow, so even with chest compressions, your cardiac output is much diminished. I am of the view that there was very significant cerebral damage at that point.
So bearing that in mind, but just dealing with, for completeness, the consideration of the use of atropine by itself, Fred Thompson's witness statement indicates that he considered it during the ROSC period for bradycardia, and you refer to that in your report. What about that administration then?
I'm not critical of that. I would virtually always expect a paramedic to reach for adrenaline as their first line treatment. because fairly frequently you will see the bradycardic, low blood pressure or hypotensive patient post-ROSC, and the adrenaline is treating both the heart rate and the hypotension, and is a mainstay of clinical management pre-hospital in the UK for the post-ROSC patient.
And are there risks or problems with paramedics administering atropine?
I actually think those risks are very similar to administering adrenaline, in the fact you can, in a patient who's got a fragile heart, put them back into cardiac arrest and give them an abnormal rhythm. You can do that with both atropine and adrenaline. There are risks associated with both, but adrenaline tends to be the drug because it treats both the heart rate and the cardiac output.
And I think we heard from Professor Rutty that it would need to have been given in volume to have any effect.
Yeah.
Thank you. If I could take you just now to the conclusions of your report on the treatment of Dawn Sturgess, which is INQ 005942, page 56, and starting at paragraph 4.53. I'm just going to read through these and then just ask you if you'd like to comment upon or change any of those in the light of anything you've heard or read in the inquiry. So, at the time of the incident, Ms Sturgess presented to the ambulance service via a 999 call. The first indication was that she was fitting, then this proceeded to a cardiac arrest. The first 999 call was received at 10:14 and was categorised as a Category 1. I have no criticism of the triage or dispatch to the call. The first resource arrived on scene at 10:23, 7 minutes after the call clock start time. This is at the mean target and within the 90th centile. I am not critical in any way of the management of the cardiac arrest of Ms Sturgess. This seems to have followed RCUK ALS guidelines and resulted in a ROSC. I am further not specifically critical of the management of Ms Sturgess following her ROSC. Whilst I do hold the view that there may have been some clinical clues that Ms Sturgess was exposed to a nerve agent, given this was far from clear and a very uncommon presentation, I'm not critical that the ambulance clinicians, on this occasion, did not consider nerve agent overdose. Having said this, I would not equally not be critical if nerve agent was considered and treatment was instigated. I have considered whether Ms Sturgess would have benefited from a duodote injector or atropine. I do agree with Professor Rutty that during her cardiac arrest period, neither medications were appropriate. I have considered FT at Fred Thompson's rationale for withholding atropine post-cardiac arrest in favour of adrenaline, and I am not overly critical of this. I am not critical of any other part of Ms Sturgess's clinical care. So, Mr Faulkner, is there anything you would like to add or change?
No, not at all.
Thank you. Finally, I would like to take you to your opinion in respect of the response to Charlie Rowley. We can deal with this fairly shortly. As you do for the Skripals and Dawn Sturgess, you very helpfully set out a timeline of SWAT's encounter with Charlie Rowley at pages 58 to 59 of your report, and you summarise the events at pages 60 to 65. And as the whole report is going to be adduced, I won't take you through those. Firstly, then, in respect of your conclusions, we've heard about the step 1, 2, 3 plus training in the inquiry, and you set it out in your report. So could we go to INQ 005942, page 67, and paragraph 5.25. Could you just briefly take us through that?
So I would describe step 1, 2, 3 as an aid to clinical risk assessment. So it's a tool which helps ambulance clinicians and responders of any agency assess risk, or was used to assess risk. It talks about step 1, one person being incapacitated with no obvious reason and a need to approach using standard protocols. 2 persons or 2 people incapacitated with no obvious reason, approach with caution using standard protocols.
Can I pause you there for a moment? Just a question hasn't risen whether when counting the number of patients, the second or subsequent patient has to be present at the same time. What's your view of that?
So my view is the second or subsequent patient doesn't need to be present at the same time, and I consider it completely appropriate and commendable that an ambulance clinician thought, oh, there was a patient here earlier, I'm going to be really cautious.
That's in respect to the response to Charlie Rowley.
Yes.
And we can see there the recommendations if 3 or more present.
Yes. 3 or more in close proximity, incapacitated, no other reason.
Can we just scroll down to make sure we've got the rest of that? We've seen evacuate, communicate and advise, disrobe, decontaminate. Thank you, we can take that down. Your conclusions then with respect to Charlie Rowley and the response, and I'm looking at page 66 of your report. Could you summarise your findings and conclusions regarding the handling of the 999 call?
So I believe the 999 call was handled appropriately, triaged appropriately, and I'm not critical of either the dispatch or response times.
And this call was upgraded, wasn't it, from category 3 to category 2?
Yes.
And why was that?
My understanding and my review, it appears that a clinician in the control room reviewed the call and made what appears to be a very sensible decision to upgrade the call based on the information on it.
Was that, the information on it, was that about the fact there'd been a previous patient?
I think it's a combination of probably the signs and symptoms and then the previous patient.
So just taking you through what you say there, you've said no criticism of the call and no criticism of the grading, the categorisation. The ambulance call sign 7710 arrived on scene at 18:47, 15 minutes after the call was upgraded and inside both the mean and 90th centile response times for a call of this nature. Is that right?
Yes.
So you weren't critical, therefore, as you've said, of the response. Secondly, and I'm going over the page now, in fact, to page 68 and 5.26. What were your thoughts regarding the decision of Ben Channon and Lee Martin, the paramedics, to don PPE on attending Charlie Rowley?
I think it was a highly sensible decision based on the information they'd got about the previous call. And I think it shows a level of commendable clinical practice and foresight in thinking about that on way to the call.
Given what we know now, are you able to say what may have been the likely or practical effect of those actions?
So this is slightly difficult because back at the time of this, ambulance clinicians wearing personal protective equipment was unusual and probably would have impinged certainly their movements. It's uncomfortable. Most of us practiced throughout the COVID pandemic wearing PPE, so we're a lot more comfortable doing it and we've got a lot more adapt to putting it on and taking it off. So I suspect the effect today would be less, but it does have a marked effect on your ability to assess, treat, wearing what is in essence a coverall suit and a mask.
What about in terms of potential contamination? Would that have assisted in removing that risk?
It certainly helps minimise the risk. It doesn't remove the risk of contamination, it just minimises it and helps protect the responder.
Because we know now that they were going into Charlie Rowley's property where subsequently Novichok was found.
Yes.
Thirdly, in terms of your conclusions, what was your assessment of the clinical care given by the paramedics to Charlie Rowley overall?
I have no criticism. I, in fact, think their assessment was commendable. I think they assessed and treated both for opioid overdose and using the information and the signs and symptoms came to impression of potential nerve agent and organophosphate and managed that appropriately. And I think that is really commendable clinical practice.
You emphasise 3 specific areas upon which you comment. Could you just summarise those areas? It is page 68, paragraph 5.28 of your report.
So they administered naloxone and they were administering that to manage a potential opioid cause of Mr. Rowley's collapse. They did also consider alternatives. They administered duodote. They placed intraosseous access and then administered atropine. and managed the seizure presentation with diazepam.
So there's 3 specific areas being, firstly, the administration of naloxone
Yes.
to counter potential for opiate overdose. The second area, the use of an intraosseous device. What was your opinion regarding that?
So use of intraosseous devices on patients outside of cardiac arrest is unusual. They're normally used in cardiac arrest. And I think it just shows the high degree of concern they had about Mr. Rowley's presentation and the need to get drugs into him. Yeah.
And the third element was the use of the duodope pen,
Yes.
which you say at paragraph 5.30, page 69, the use of duodope and then atropine may have been one of the key aspects of care in terms of his survival.
Yes, as far as my expertise allows me.
So can I summarise by saying you have praise indeed for the clinicians who attended Charlie Rowley?
I think this is a level of clinical insight that should be commended. Yeah.
Final topic then, the command of the incident. Could we go to Appendix 2 of your report, INQ 005942, page 85. We see there, and we've had substantial reference to the Jessup principles, or as you describe them in your report, the Jessup doctrine. What was your view in terms of whether the ambulance personnel applied these principles when attending Charlie Rowley?
My view is the ambulance clinicians attempted to apply these principles, particularly around communication and particularly about trying to share a joint understanding of risk.
We've now heard evidence from Ben Channon and Ian Parsons having attended the Skripals, regarding their convictions that this was a second nerve agent poisoning. And we've heard from Acting Police Sergeant McCurley and Inspector Beresford-Smith, the police officers, who decided to treat the incident as drug-related, notwithstanding the paramedic concerns. Is it fair to say that in your report, you question the professional respect accorded to the ambulance personnel by the police, but you caveat by saying that you defer to an expert in policing with regard to the action of the police?
Yeah, I'm clearly not an expert in policing, and I wouldn't ever want that. But I do feel, as an operational paramedic, when you're expressing a concern that I'm really worried about this, because this is what I'm seeing clinically, as a clinically trained, educated individual, to have those dismissed is probably substandard.
I quite understand that you can't set yourself up as an expert in what the policeman ought to have done or ought not to have done, though I may have to consider it, well, shall have to consider it. What you can tell me, I think, is your view of the reaction of the paramedics when they were confronted with that disagreement.
So I think it would have been all too easy for those paramedics to revert to what the police were telling them, lose confidence in their clinical convictions and gestalt, and go, well, this is probably just an opioid overdose, the police have got intelligence on this.
Yes.
These are clinicians who I cannot commend highly enough. So despite having counter-views put to them, continued with a course of treatment that ultimately was correct based on what their clinical indication from their clinical background and knowledge was.
Okay, thank you.
If I could just pick up that topic, under Jessup, from a paramedic perspective, first, ought the paramedics to take account of information or intelligence provided by the police generally?
Yes, it's a joint understanding of risk, which flows both ways, or flows between emergency services.
Secondly, and relatedly, would information regarding the use of drugs or the finding of drugs paraphernalia at a location ordinarily be relevant to paramedics seeking to determine how a collapsed patient might have fallen ill and what treatment's required?
So it all forms part of the clinical picture, but you always have to be minded that you don't bias that.
And thirdly, if there's a disagreement of the sort that happened in this case, whose decision on how to treat the patient should take priority?
The ambulance clinicians as a clinical team.
And whose decision on how to manage the scene should take priority?
So I think that is a shared decision between all three emergency services, but specifically around scene safety, preservation, sits with the fire brigade and the police.
can I just ask you what the key differences were in the presentation between Charlie Rowley and Dawn Sturgess that perhaps may have made it slightly easier for the paramedics to identify nerve agent poisoning with Charlie than with Dawn?
So Charlie Rowley, I bet, had a reduced level of consciousness, but was not unconscious. He was not in cardiac arrest. My understanding was he was still standing when the ambulance clinicians arrived. They describe a level of, I think, what might paraphrase as muscular rigidity. Those are all unusual in somebody who's taken an opioid taken an opioid overdose. I think you've heard evidence that they described him as mooing or making mooing noises. That again is unusual. And all of that points you away from an opioid cause. And those clues weren't there when the earlier ambulance clinicians attended Dawn Sturgess.
Was a relevant factor also that he was the second patient to present?
Absolutely.
You indicate in your report, page 70, paragraph 5.34, that you're not critical of the time taken at the scene, as that was spent usefully providing Mr. Rowley with life-saving interventions. That
Yes.
correct? And you also say, I'm not critical of the decision of the police officers who'd been within the cordon to drive the ambulance to the hospital. As I said earlier, we now know that the house in which was one in which Novichok was found. Was there not, in your opinion, a risk of contamination by driving the ambulance rather than fire officers in PPE?
I think there was a risk. I think that would have been minimised by fire officers in PPE. But equally, probably on balancing that risk, the other alternative was one of the ambulance clinicians would have got out the ambulance, doffed their PPE and then had to get into it, which probably further increases the risk of contamination.
And lastly, if we could go to your final summary in your report, which is at INQ 005942, page 81. Again, I'm just going to read this through to you and then ask you if there's anything you would like to say or change in respect of that. So you say, in final summary in your report, I have considered with a great deal of care the evidence that has been provided to me and submitted before the Dawn Sturgess inquiry. The events of 2018 in the Salisbury area were completely unprecedented within UK pre-hospital care. The exposure of not just one but 4 people to a neurotoxic nerve agent such as Novichok led to widespread and long-term effects not just on those involved as patients, but on responders, bystanders and the wider community, as well as nationally and internationally. Where I've been critical, albeit this is really limited, this criticism must be taken against this incredibly unique and unprecedented backdrop. The language in this report is necessarily clinically stark in places, and I do apologise to anyone reading for any upset that this may have caused. To Mr. and Ms. Skripal and Mr. Rowley, I wish them a continued recovery and my best wishes for the future. To the family and friends of Dawn Sturgess, I would like to offer my fullest and most sincere condolences. Whilst I'm aware that nothing within this report can begin to make up for their tragic loss, it's my hope that this report may provide some answers to many questions that they will have. Is there anything you would like to add?
No, thank you.
Thank you very much. Those are my questions for you. So I don't know if there are any.
Yes, thank you very much, Ms. Whitelaw. Now then, are there any questions?
So yes, I think I can ask them in 2 minutes,
All right.
if I may. Mr. Faulkner, my name is Jesse Nichols and I ask questions on behalf of Dawn's family.
Good evening.
I'm conscious of the time, so I'm just going to ask you a couple of topics very briefly. The first relates to paramedic diagnosis. Now, it might seem a little time ago, but you touched on this with Ms. Whitelaw earlier, and you said in your evidence there will be times that paramedics reach a definitive diagnosis. That is not uncommon. And I understood you to be saying that is an appropriate thing to happen.
Yes.
You also said there will be other circumstances, and you've used these words, often you're unable to get to a definitive diagnosis and you will form a list of impressions.
Yes.
And that is also appropriate in certain circumstances.
Yes.
Is there also a third category between the two where a paramedic reaches a working diagnosis based on their assessment, but they can't reach a definitive diagnosis, and that is also appropriate?
Yes, I think that's reasonable.
Second and final topic, please. In the answers you gave a moment ago to Ms. Whitelaw, you explained that if the situation arises that arose in respect of Mr. Rowley's treatment on the evening of the 30th of June, if there is a disagreement of the kind that took place, the ambulance service decision on treatment should take priority.
Yes.
If the ambulance service assessment of the patient, that is to say in relation to treatment, impacts on scene safety, for example, because they are identifying the risk of a chemical poisoning, does that at least need to be taken into account by the police and the fire service?
So I am not a police or fire expert, and I caveat my answer, but yes, I would expect them to take it into account. But I clarify that absolutely, that I'm not a police or fire expert.
I understand. And final question, please. Given the disagreement that occurred and the dismissal or lack of professional respect that you've described in your report, are there any points of improvement or learning that you can identify from this incident, the evening of the 30th of June 2018, that would help to prevent that situation arising were it to happen today?
I believe the Jessup principles are very easy to stand in a setting like this and bash and beat up. But they are really solid, well thought through principles. I think this is all about sharing learning, professional respect, and really embedding those into practice in emergency services. I think they are solid principles. I don't think they're fundamentally wrong, and I think it's about how individuals choose to interpret that at the time.
And so if there were inadequacies, that of course being a matter for the chair, in this case, you see that as a failure, you may use another word, to apply those Jessup principles?
I think I say this again.
That isn't for him, you know, really, Mr. Nichols. I understand exactly why you ask it, and you're going to make the comment in due course. And it's there to be made, but it isn't actually a question for his expertise.
Well, then I'll leave it there, sir.
Thank you very much.
Thank you very much, Mr. Faulkner.
Were there any other?
No.
No. Right. Ms. Whitelaw, anything else?
No, that is the evidence for today. Thank you, sir.
Well, that's very tidily done. From the point of view of time as well as other things. Mr. Faulkner, thank you very much indeed. Those are all the questions we have for you. There's no need to stay in future unless you want to come back and listen, which of course you're entitled to do. But I'll rise now. 10 o'clock tomorrow morning. Level 1, I think.
Oh, it is level 1.
Level 1. Very well. Thank you very much indeed. 10 o'clock tomorrow morning.